Tell me when.
Okay, is recording in progress. Okay, you can start now.
Okay. So, my name is Wendy Perrott. I'm an OBGYN. I practice in Florida. I'm board certified in OBGYN. I've done women's health for the last over 25 years in this area. I'm also board certified in lifestyle medicine as well. So when I talk about hormones, I'm actually looking at it, not just telling you about hormones, but trying to look at it in a holistic fashion so that we can see how we can balance hormones, not only by throwing hormones or medicines at you, but by changes in your lifestyle as well. Okay. So there was a book that was entitled by Elizabeth Villette, and it was entitled "It's Your It's My Ovaries Stupid." Basically, that's what's the title of the book. It's My Ovaries Stupid. And basically, what she was trying to show is that the ovaries and all the problems that we women have, like migraine headaches, foggy brain, irregular period, premature ovarian syndrome, puberty issues, fatigue, loss of sexual desire, mood swings, mood changes, allergies, skin problems, whatever. It's all because of our ovaries. Basically, that's what she's trying to say. And really, it is actually true. We are more run by hormones than we think. And so, what I want to do today is to, if you would permit me, to look at hormones. I want to show you hormones from go back and look a little bit at the hormonal web. That is where it comes from, what it does during your reproductive years, and also look at briefly mention what are the sex hormones that we encounter, like estrogen, progesterone, testosterone, etc. A little bit about that. The perimenopause and the menopausal phase of our life, how we value it, how we treat it, and if I have any more time, I can present to you 3 case histories of my own patients that I have seen, different age groups that I have learned through them to balance their hormones, and of course questions. And we can leave out any part of it if we need to, if time is an issue and we need to leave time for questioning. So, so God did not. I always start my lecture whenever I start out, any lecture on hormonal replacement therapy. I always say God did not intend us to be on hormonal replacement therapy, but He didn't invent stress. So here we are, you know, trying to uh, balance our hormones. Now, I don't know if you have ever heard about the limbic system. The limbic system is an area of the brain that deals with emotions. It's the seat of our emotions. And the hypothalamus is in that area, and the pituitary is in that area. Um, and the hypothalamus is what signals the pituitary to produce a releasing hormone. A releasing hormone, excuse me, is produced by the hypothalamus, which goes to the pituitary, and the pituitary produces stimulating hormones, and then the stimulating hormones go to different parts of the endocrine system of our body. So you understand that in the limbic system is where all of this starts in our brain, limbic system. So therefore, the hormonal system requires a balance with our body, with our mind, and really with our spirit. And so hormonal balance then is easily thrown off by emotions because it comes from the seat of our emotions. Okay. So the hypothalamus, in review, the hypothalamus is the first player. It sits in the midbrain and receives messages from the limbic system in the brain telling it to release hormones. It communicates with the pituitary gland, which releases something called FSH and LH to the ovaries, and it produces eggs and your hormones. And that's kind of how it works. Now, there are other releasing hormones as well that goes to the thyroid, for men, the testis, it goes to the pancreas. I mean, there are different releasing hormones as well. But today we're going to talk about those two. So the ovaries produces estrogen, progesterone, and testosterone as a result of this command of the pituitary. And once these hormones are released, they do their job. And for estrogen, for instance, it's at least 400 functions in the body. That's how significant estrogen is. The main job is to support the entire genital area, the bladder, GI, and the bones. Now, when a hormone is released, it goes to the different parts of the body, and it forms what we call a hormone receptor complex, a hormone receptor complex. So all cells in the body produce hormones receptor sites, and they are specific for each hormone. The hormone is specific to each receptor site. So the receptor site of progesterone is different from the receptor site of estrogen. Only estrogen can dock on that receptor. Only progesterone can dock on that receptor. Or sometimes you have different things in our food that fool us. So hormones are specific for each receptor site. And when they dock on that receptor, it forms a receptor complex. Now, there are abnormal hormones obtained from processed foods, and they can also dock on that receptor site, produce abnormal estrogens. And I'll talk a little bit about that and later. So once the hormone binds to these receptor sites, they form a complex, and the hormone receptor complex is what does the work by creating a protein messenger that will set off certain events in that part of the body. So you see how specific that is? Now, the ovaries, as you know, produces all of these hormones. The midpoint of your menstrual cycle continues to see a rise in your estrogen level. The pituitary then produces LH, and the LH is, we're not really sure what makes the pituitary do that, but this is what actually caused the egg to be released, and therefore estrogen to be produced from the cells around the eggs. At about 20 weeks of gestation, we have about 10 million eggs or ovum at 20 weeks. At birth, we have 1 million. So 10 million to 1 million. At puberty, we have 300,000. And you only ovulate 300 to 400 times in your lifetime. So after a while, all of these eggs die. What makes them die? They're pre-programmed to die. About 1,000 of them would die every single month. So there's pre-programmed apoptosis. How wonderful that is. So a menstrual cycle can be disturbed by extremely subtle changes. We have all heard about the dominant female, a phenomena which causes all women to have a period at the same time. You've heard about that. These dominant female produces the most powerful pheromones, and we smell it. And therefore our cycles begin to, they would cycle together. So women in a dorm, I don't know if anybody have lived in a dorm, but I have. We all had a periods together. It's because of these pheromones. Quite a very interesting thing. So any disturbance in this concert can severely disrupt a woman's health and create a host of problems, including fibroids. So you see how delicate that situation. Stress is very, very this cycle, excuse me, this web is very sensitive to stress, and stress puts it off in all kinds of direction very, very easily. So the menstrual cycle can be influenced by stress, by hormones, and by lifestyle. So then, now that I've told you that little area, I want to say this, that women who are perimenopausal and menopausal somehow have gotten neglected by doctors. You know, they would come complaining of migraine headaches or mood changes or whatever. Nobody ever actually thinking, well, maybe let me check their hormones. Maybe their hormones need to be balanced, rather than throwing migraine medication at you, or mood changes medication like Prozac and Zoloft at you, rather than balancing your hormones. So I think it's an area of medicine. It's a group of women from the 40s who get neglected by certain complaints. And I think also that women are scared to ask and to talk about it as well. But menopause is a natural biological process that occurs in every woman, basically. Menopause can result from other things too besides something natural. It can be from surgery, a hysterectomy, but your ovaries removed, chemotherapy or radiation surgery, which kills the ovary, can also cause early menopause as well. But menopause provides an opportunity to start a new lifestyle. I want you to look at it that way. Menopause provides an opportunity to start a new lifestyle. What's the definition? Menopause occurs and is confirmed by 12 months in a row without a period. So 1 year, no period, that's the definition. That's the medical definition of menopause. Perimenopause, however, is the span of time before your final period. And then postmenopausal years is all the years after your final period. The average age of menopause is 51. And perimenopause can occur 5 to 8 years before that time. By the way, it is genetically programmed and is familial, meaning if your mother went through menopause at 48, chances are you may go through menopause about the same time as well. So surgical menopause, as you know, can occur if the ovaries are removed and if the ovaries are removed with the uterus. Menopause can occur as early as 45 and can go as late as 55, 51 being the most 51 being is the average age. So the symptoms of menopause could be different for everyone. Some women feel no symptoms at all, and some women have severe symptoms which interfere with their life. These are the ones that I deal with the most. They would come into me and they would say, I feel like a train without a track. They would be crying, angry, irritated for no reason, can't sleep. It was a very profound symptom. And not only irritated, but cannot seem to handle the stressors that they would have handled in the past. And that's from symptoms of menopause. So when estrogen level and progesterone too falls, some women experience an uncomfortable symptoms. Among the most common, as we know, is hot flushes and night sweats, but vaginal dryness can also be as well. Itching, irritation, burning, painful intercourse, and then of course bone loss, leading to osteoporosis. But the most common is hot flushes because probably up to 90% of women would have hot flushes, and some women will begin to have hot flushes 3 to 4 years before the final period. So what is a hot flush? It is a sudden feeling of heat and intense sweating, often accompanied by increased heart rate and sometimes by chills. Some are easy to ignore, but others can affect your life, you know. Hot flushes can begin early in perimenopause and are most common during the first 3 to 4 years after menopause. Some people say it goes away, and some of my patients say it never goes away. So it's reported in as much as 90% of women. There are also vaginal changes too that can occur with menopause, such as the lower estrogen can lead to decreased lubrication and thinning of the walls and increased and frequent urination as well. You may have vaginal dryness, which may lead to difficulty with sexual intercourse. Bone loss, very important. Women may experience rapid bone loss, and the rapid bone loss occurs within the first 3 years after menopause. You can lose up to about 20% of your bone in those 3 years. So that's very important that you exercise and build bone again if you choose not to do any estrogen therapy, or if you choose to do estrogen therapy. We know that estrogen replacement can actually improve and slow down bone loss. So let me deal a little bit with what are these hormones. I'm going to deal with 3 of these hormones: estrogen, testosterone, progesterone. But there are other hormones in that concert as well, such as melatonin and insulin. I don't think I have enough time to deal with all of that, but I will deal with that. And I'll talk about evaluation and how we treat this, especially with bioidentical hormones. So what is estrogen? There are three kinds of estrogen. We know one called estrone, we have estriol, and we have estradiol. And when you hear about estrogen, we're mainly talking about estradiol. Estradiol is it's the strongest, most potent of all the estrogen. And when I replace it, I tend to replace it in a bioidentical type of way, and I'll tell you about that a little later in this talk. But estradiol is the one actually that does the job. The 400 functions of estrogen that you hear about, estradiol is mainly the one that does that. So what does it do? Estrogen improves sleep. It increases sexual interest. It maintains memory. It decreases blood pressure. It increases metabolic rate. It decreases depression, irritability, and anxiety. That's only a few of the things it does. Remember, I say it does 400 things. But here is something I want to say about estrogen. When you are in utero, estrogen works on the brain. Estrogen is responsible for neuronal birth, the formation of neurons. Estrogen is responsible for the communication between neurons. I don't know if you have seen a picture of a brain cell. Where do you see it looks like little tendrils sticking out, or what we call the dendrites, like branches. Estrogen is responsible for developing those branches. So one neuron could communicate with the next. Estrogen is responsible for even clearing out amyloid plaques. Estrogen increases the brain-derived nutrigenic factor, which cleans the brain out. So therefore, when you become menopausal, now you understand why women complain of foggy brain, lack of concentration, irritability, mood swings, things that happen to their head. Where did I put this? Where did I put my car? Where did I put my keys? Those kinds of things. It's because our estrogen levels have declined. The only thing I know to improve that, the two things I know to improve that, is I had to give back some estrogen therapy, and two, exercise. Exercise is the alternative to estrogen therapy for women to maintain the connection between one neuron to the next and do the thing that estrogen used to do for you. But when you have to exercise about 30 minutes a day, and you have to sweat, you have to actually exercise until you're tired and sweat to get the brain-derived nutrigenic factor to increase. So and I've seen this happen with me, actually. I've seen one day, I'm like, whoa, I could think, I could remember when I began to do that. You have, and not, this is not strenuous exercise. You just have to exercise until you're tired. And that sometimes involves just 30 minutes of brisk walking. So that's estrogen. Progesterone, on the other hand, is estrogen. It's a natural diuretic. It improves sleep. Even a mood stabilizer. It's an anti-anxiety and antidepressant. So over the last year, I've been seeing a lot of young people with anxiety, young women with anxiety. And when I check their progesterone level, it's less than 1. I would check progesterone level at day 21. During day 21 is when you should have a peak in your progesterone level. It should be somewhere between 5 and 15. And their progesterone level, is 1. And just replacing them with a little bit of natural progesterone improves their sleep, chills them out. And that is because all of the processed food that we're eating, or I don't know, social media, but everybody's anxious these days. So testosterone. Now, what does that do? It increases sexual desire or sexual interest. It increases a sense of emotional well-being. It increases muscle mass and strength. It decreases excess body fat. It helps skin from sagging. It helps to maintain bone strength. It maintains vaginal wall thickness. And you can deliver it in several ways. Some people deliver it by the skin. Some people deliver it by a pellet. Some people deliver it through the vaginal mucosa. GI, not as good because it's not very well absorbed. Now, I want to say something about something called xenoestrogen. That's Xeno estrogen, xenoestrogen. You know what they are? They masquerade as real hormones of estrogen. They are found in things like pesticides, insecticides, plastics, DDT, organic solvents, PCB. They are xenoestrogens. They act as foreign estrogen when they arrive in our body. They disrupt. Remember, I talk about how each hormone has their own receptor. Well, these behave like estrogen. They mimic estrogen, and they go on. They dock on your receptor. They act as foreign estrogen. When they arrive in our body, they disrupt the precision or the balance of our system and create an estrogen dominance, because you have all this estrogen floating around, but they're not good estrogens. That's the kind of thing that causes the breast cancer. The fact once an estrogen occupies a receptor site, that site becomes resistant to natural estrogen. So you know you have that xenoestrogen there, but you have your natural estrogen floating around, no place to dock. And now it has time to go and cause DNA damage and all kinds of stuff. So xenoestrogen is not natural to us. Interesting. But flaxseed has a soluble fiber in it called lignans, Lignans, lignans. And lignans, if taken on a daily basis, 1 to 2 tablespoons of ground flaxseed a day, can flip these abnormal estrogen and cleanse your receptor site. Fearfully and wonderfully made. So how then do we assess what's happening to us? Estrogen therapies. So if you have been bothered by irregular periods, hot flushes, night sweats, vaginal problems, mood swings, irritability, foggy brain, lack of concentration, forgetfulness, if you have been plagued by that and you go to a doctor, he or she should be able to check your hormones. And the way I check it, I look at hormones in 4 areas. I look at your blood sugar dysregulation, because if your insulin level is high, if your insulin if you're suffering from insulin resistance, you will get hot flushes. And it's not much to do with with other hormones at all. So I look at that. I look at your thyroid. If your thyroid is not working well, you will get hot flushes. Of course, and I look at your stress level. If your cortisol level is high, you also will get hot flushes as well. If it's too low, you will get hot flushes. And then I look at your estrogen level and the progesterone level, testosterone level, and sometimes I throw in there a DHEA as well. So those are 4 areas how I evaluate patients. I look at it in 4 areas. And so with those 4 areas, after I get that lab report, then I come together and then we decide now to actually begin to balance your hormones based on what you're missing and also your lifestyle as well. Because if I can sharpen up your insulin, I can actually get you to have literally no hot flushes. Let me say something about breast mammograms, by the way. The radiologist is required by law now to document the what we call the breast density. So they will put on the mammogram breast density 50%, breast density 75%, 10%, 5%, whatever. That is important for a doctor who is doing hormones, because if you have a breast density that is beyond, say, 75%, and you come in with hot flushes, and I throw hormones at you in an indiscriminate fashion, I can now increase your risk of getting breast cancer. So it's important that we know the breast density, so I know how much hormone to give you, what to give you, how to get that density down so that I can give you hormones. None of this stuff here I learned in medical school, by the way. It's something that I've learned through my patients asking me and having me read a little extra so that I can actually better able to solve their problems. So how do we treat hormones? What we do, if a patient comes in and she has hot flushes, she said, I feel forgetful, I can't sleep at night, very common complaint. What do I do? After I evaluate the hormones and I look at the levels, then I begin to treat. Well, some patients don't want any treatment. That's okay. They can write it out. There are times when, according to the textbook, it may take 3 to 5 years for some of these hormones to kind of get back and all the hot flushes to go away. But there are benefits with using hormones early in menopause, in the first 3 to 5 years of menopause. In fact, the first 10 years after menopause, there are some benefits. So, so not treating symptoms is one way to go. Lifestyle changes is another way to go. So smoking cessation, regular exercise, weight control, stress reduction, diet management, especially whole food, plant-based. Some people do say, well, I don't want any prescriptions, so I have a list of supplements that they can take, vitamins, minerals, some over-the-counter natural botanical phytoestrogens, vaginal lubricants and moisturizers, and of course, there is the prescription hormones. Prescription hormones, as you know, are approved by FDA, and they are approved to treat osteoporosis and moderate to severe hot flushes. Estrogen is always given with a progesterone. If you have a uterus, but if you don't have a uterus, we can give it without a progesterone. So if you are bothered by hot flushes or night sweats or vaginal dryness, you may want to consider hormonal replacement therapy. But the decision to use hormone replacement therapy must be based on the individual treatment goals, benefits, and therapy. And there are choices. If you have osteoporosis, we can treat that. If you and with estrogen as well as with non-estrogens as well. So I want women who use hormone replacement therapy should use the lowest effective dose for the shortest consistent with the treatment goals and the risk for the individuals. What I'm saying, you should use the lowest dose and shortest period of time. And what we do is to start hormone replacement therapy right after menopause within the first 3 to 5 years, and to continue it for about 10 years. And after 10 years, I begin to taper my patient. By then I have drill in their head, exercise and lifestyle changes, which I believe will carry you along. So some people, and I've had a few women who requires just a little bit of beyond the 10 years, and I have followed them and given them that. So let me talk a little bit about bioidentical hormones, because I do not use synthetic hormones in my practice at all. What are bioidentical hormones? Bioidentical hormones is similar to what's found in the human body. So estradiol, estrone, and estriol, progesterone, and testosterone, and of course DHEA. They are identical in chemical structure and activity to hormones found in the human body. And most of them are derived from wild yams and soy, especially wild yams. They are derived from wild yams and soy. And so the pharmacists, who it has to be a compounding pharmacist. So the typical pharmacy like Walgreens and CVS and Publix, some of them, although Publix now have a compounding pharmacy, do not compound. It has to be a special pharmacist and a special pharmacy that does that. Why I like compounding? Because why do I like bioidentical? Because bioidentical really, it's unique to how much you need. It's not a one size fit all. So if I look at a patient lab and I see that they require a certain amount, I can tailor my dose for that patient. And if after I have her on it for 3 or 4 months, I realize she needs a little more, I can go up. I cannot do that with synthetic hormones. Now, there are some bioidentical hormones that are by prescription, and you can get that, but it's a one size fit all. So in other words, somebody needs, say, example, progesterone. Progesterone comes as a bioidentical by prescription, 100 milligrams and 200 milligrams. What say a patient they need a little more than 100 milligrams, but 200 is too much for them. There's nothing we can do about that. But with a bioidentical, I can do 125, I could do 150, I can tailor-made it for the patient. That's why I like bioidentical. Over the last few years, I have had a running chart of patients who developed breast cancer in my practice, because I wanted to see if my bioidentical hormones is causing or is associated with any way with breast cancer. I have not picked up one yet in 20 years. Breast cancer in my patients with bioidentical hormones. I have picked up with synthetic, but more so I have picked up with those who are no hormones at all. There are more breast cancers I've seen in patients who are not on any hormonal replacement therapy, but none so far in my bioidentical, knock on wood, bioidentical hormones. So when I give estrogen, then I give it transdermally because estrogen works better transdermally, if meaning through the skin. So I develop it, I have the compounding pharmacy, which is right downtown in Eustis, where I practice, develop this cream for me, which I'm able to use and on the skin. I have patients on the skin on a daily basis, and I use estriol and estradiol. I do not use estrone because our bodies already produce estrone, so all I do is give the two. And then I use progesterone as well. Sometimes I put the progesterone in the cream and have all three creams, all three hormones in one cream, or sometimes I use the progesterone by itself orally. And the reason why I do that is if the patient is complaining of sleep issues, progesterone behaves like a sleeping pill. When it's metabolized by the liver, it's metabolized into a form that actually puts you to sleep. So sleeping is an issue, you use the progesterone as an oral form. I use the estrogen non-orally because a oral form of estrogen is associated with blood clots, and the transdermal form is not. So so that's where we are. I don't know if I have time to do a case, or do we need to stop right now and do, since it has been about half an hour since, I do,
Yeah.
what do I need?
Yeah, I'm sure we have lots of questions. So maybe we can spend the next 15 minutes answering questions because this is
That's
such a
correct.
very
That's why
important, yes, such a very important topic. And I'm sure our audience might have some questions. So at this time, we are opening up for questions. So guys, if you want to write your question in the chat, you feel more comfortable writing instead of, asking the question, you can do that, or you can raise your hand and we can get to you to get your question. So at this time, we are open up for questions. You should have questions because this is such an important topic, as a topic that is not, explained to a lot of women. Because I know some women, I've heard women say that they're not going to take any type of hormone replacement because of the fact of cancer. We have heard that, we have seen it in studies where cancer is, increases if you take any type of hormone replacement up to like 5 years of hormone replacement, you increase your chances over 30% of getting breast cancer. But we found there's another way you can do this. You don't have to take those synthetic medications. So,
right.
yes. So let's, no one is in the chat. No one is having any questions. I know I have some questions from Dr. Perrott. You talk about the estrogen, estradiol, you use it transdermally. So is it important to put it in a certain area of the body, maybe over a fatty area, or can you put it over bony, because I know some medications.
Good question. Good question. So what works better, you want to apply it in an area that's a little fatty. So usually I have patients apply it on their thigh, see area. So some people put it on their abdomen, but I find that the abdomen is such a big area and it can go anywhere. So usually on the thigh, and I have patients put it on their thigh and rotate. Some people put it on their wrists as well. This right here, because there's some blood vessels right there. And you can also do it on, and you alternate.
Right.
Some of the bioidentical ones that are by prescription, they were studied to be placed here on the arm. Some of them were studied to be placed here. So there's because you want to put it in an area where there's not much hair and where there's some fat, basically, so it can get absorbed. And transdermal estrogens gets absorbed in a pulsatile fashion. What that means, when your ovaries produce hormones, it produces, everything in our body has a rhythm, and a pulsatile way of producing it. So it will produce it boom, 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 and stop. You know, it was just in a pulsatile fashion. So when you put it on the skin, it somehow is absorbed in a pulsatile fashion, just like what the ovaries does. So the body is able to recognize it better. And so if you take an oral dose, it goes to the liver and does all kind of wild stuff so that it can actually increase your risk of getting blood clots when you do it that way.
Okay, yes, that's good to know. Because I've heard where blood clots are formed from estrogen replacement therapy. And it's
That's correct. But
because
it's the oral
oral
estrogen
form,
that does.
oral form of
Yeah.
it. Right, right. Okay, so we have some questions. Let me see. Oh boy. So we have a question here. Dr. Perrott, this was an excellent presentation. Did you say that you can decrease, I guess, breast density? Oh, this person wants to know if you can decrease breast density.
Good question. I'm glad somebody asked that. I didn't have enough time to say all of that. Remember how I say that that there are some women who just simply normally have dense breasts, and
Right.
when by law over the last 2 years, by law, the radiologist has to actually say on his report the percentage of breast density, because somehow with people who have lots of density, you cannot see a breast cancer as easy as somebody without a breast that's dense. And so there are ways to decrease breast density. One good way is actually to eat foods that are not, whole food, plant-based. Like, how many times do I have to say this? Which is low in fat, low in saturated fat. But if you go to your supplement store, go on Amazon and get iThroid, Throid, which is actually a kind of an iodine. It will decrease breast density in 3 months.
You said
Okay?
iThroid.
iThroid. Yeah, iThroid.
Okay.
iThroid.
Okay.
Yes.
Wonderful. Okay.
And that will decrease breast density for you
Yeah.
as well. But the best is with foods, whole food, plant-based. That will
Right.
reduce your breast
Right.
density for you.
Right. Okay. So the saturated fat is what's causing this breast density. And so
Yes.
yeah.
And so we can't see. So if a patient comes into me who has a breast density of 90%, and in the past, what we used to do, we never looked at breast density. So we throw hormones at them. They could have a breast cancer hiding in there, and I don't see it, right? So the mammogram is normal. So what I do, I look at a breast density, I'm like, oh my goodness, I don't think I could treat you on hormones right now. Let's see if we can reduce some of that breast density. So now I begin to do things to reduce our hot flushes that have nothing to do with hormones. I may do intermittent fasting. I put you whole food, plant-based, nuts, flax seeds, some certain supplements to actually give her some relief of her hot flushes and the menopausal symptoms while I reduce those breast densities to see if there's anything.
Okay, wonderful.
It's a holistic approach to this whole thing.
Right. So you need to find doctors who deal with both holistic and conventional, because it can really help you, very far, take it very far. Someone is asking, where can you find these hormones that will not cause cancer? I guess the
very good. So she's asking, where could you find bioidentical? Very hard to find. It was, listen, let me just tell you a quick story. When I started doing this, I didn't learn this in medical school. The synthetic hormonal pharmaceutical rep, I remember them always. I went to Loma Linda. They were always there. They gave us books, they gave us pens. I mean, they were always around. And so by the time you come out of a residency in medical school, it was like a no-brainer to write a prescription for Premarin. It was like a no-brainer to write that, because they so indoctrinated you with this. Until one day when I came on, a patient says, she brought me a prescription of this thing called bioidentical. This is 25 years ago. I'm like, what is this? And so because I listened to my patient, she started talking to me. I started to read. I ended up calling her pharmacy, there was none in Florida. I ended up calling this pharmacy in Wisconsin, develop a relationship with this pharmacist in Wisconsin, learned about bioidentical. through that. So my patients taught me.
Mhm, mhm.
about. So you have to therefore go to a compounding pharmacy, a pharmacy that makes these creams, and there are a few now, a lot around now. It's not like how it used to be 25 years ago. There's quite a bit now.
Right, right, right. I know,
That will make,
yeah, I know there was one in Orlando when I was living there. When I was, so you need to talk to your doctor. You need to ask questions. When you go to your
is
doctor,
that
ask
correct?
them
And
questions.
that's
Like,
correct. And
like,
there's some
yes,
doctors who need to learn.
right.
Yeah.
Like Dr. Pearl, she learned about it from a patient. So maybe you might be the
Yeah,
one introducing this to your doctor and they can do some more research
exactly.
and find, yeah, but they're
Yeah,
there.
and it's interesting. They brought me books. I had books. They brought me books. I read 3 or 4 books that patients brought me about bioidentical hormones. They brought me books about, and I read them. And
Mhm,
I said, let me read it and let me discuss it with you. And that's how I learned. I learned because the patient was asking.
mhm.
And they were asking, and I learned. I learned. That's how I
Right.
learned.
Right, right. Wonderful. It's always good to listen to your patients. You learn from them too. Someone is saying it will be great if you can return and talk about insulin. Thank you, Dr. Pearl, for the excellent presentation. I'm sure we can get Dr. Pearl back because Dr. Pearl is a wealth of knowledge and she loves educating people, educating her patients.
That's right.
And
Yes.
those of you
I
who,
would love
yeah,
I would love to come back and talk about insulin. It's quite an interesting hormone.
yeah,
It's getting a lot of play. And by the way, it's so associated with estrogen and all
mhm,
your sex hormones
right,
and PCOS and things like that. Yeah.
right, right. So those of you who live in Central Florida, Dr. Pearl is right here in Central Florida. You can, you can get to her and she can start treating you for and prescribing these bioidentical hormones so that you can use and so you can feel much better. So I heard you talk
Yeah.
about yes, about libido. I know this is something that people don't talk about, but it is real. So you're talking about that you can treat libido because
Yeah.
there's some of us women, we our libido is just like going out the window, and it's all because of hormone problems, so
Yes.
can you kind
Yeah.
of talk more about,
Yeah.
because vaginal dryness and all those things could be sexual intercourse could be very
Yeah.
painful, and so
Yeah.
therefore women are discouraged. So
Yeah.
away from
And
there.
and interesting, they would not talk about it. It's one of this area of menopause and menopausal symptoms. Women don't talk about, doctors don't ask. Right? So
Mm-hmm.
I think it's a group of women, the perimenopausal woman who is in her 40s, late 40s, is a group of women that's ignored where this is concerned because she may come with migraines, vaginal dry, she may come with increased urination. She may come and nobody dare to say, okay, let me see what the hormones are doing. So and if sexual desire is one of them. That's another thing that I learned. Because at the same time, 25 years ago, I begun because I got so sensitive to women and their hormones, I began asking the question. I began saying, do you have any problems with sexual desire? And if there were 20 women, 18 of them are saying yes. Okay. I'm like, oh my goodness, I don't know what to do here. So I got to the point where, oh my goodness, I don't know let me stop asking this question because I'm not really sure if I know what to do. I learned over time how to balance hormones, but for sexual desire, it involves a little bit more. You have to have a sense of well-being. It's because it's not just throwing hormones at you. So I began replacing testosterone, and I replaced testosterone in several ways. This is before they had pellets, by the way. I replaced it with creams. I replaced it with troche. I replaced it with testosterone injections. I used to give injections, testosterone injections for women to improve their desire, and it worked. But really, what I have found that works the best as an adjunct to that is a sense of well-being and spiritual health, even. It was a
Right,
sense of well-being, the need to have
mhm,
improved desires, not just simply testosterone only,
right,
you
right.
know.
I can see that. That self of well-being is so very important because if you don't
Right.
feel good about yourself, you cannot share yourself with anyone else. You cannot,
Exactly.
you won't be able to, you won't be willing to do that. So I can see that self of well-being playing a very important part. So you said
Do
you
you
replaced
remember?
testosterone. Yeah.
Yes, I replaced testosterone. No, go ahead.
Yeah, you were saying you
Yes.
replace the best way to replace testosterone is with pellets.
No, I'm saying there's several ways to replace
Oh,
testosterone. Pellets is one, cream is the other,
okay.
other way, and injections. I replaced it. I never used pellets because at the time we just tell pellets is a recent thing, you know. So when I started with creams. I started with something called troches. Troches are like sublingual, and then
Mm-hmm.
I started with with transdermal. So transdermal injection and troches. That's how I replaced it. And then of course they came up with the pellets, which I never used because I don't think I could control it. So as much as my
Right.
others, I could
Right.
control it
Oh, okay. I see.
a
Because with
little
the
bit better.
pellets, yeah, they insert it under the skin. The
Yes,
little
understand.
balls that insert under the
Yes,
skin is therefore because once you insert it, you cannot extract it.
yeah.
Once you insert
Um,
those pellets, can you extract them?
you can't extract it. It's done for 3 months. It
Right,
doesn't wait
right,
for 3 months.
right. So
You can't
therefore,
extract it.
okay.
You're right. I
Oh,
personally, my personal thing is creams. I like creams because I
mhm.
feel I could control it. I could
Right,
control how much I use, how much I don't use on patients. I could control it. Yeah.
right. So that's wonderful. Um, let's see, there's any more questions here in the chat. Um, wait, hold on a second. Okay, say a little more. Say a little more oral progesterone as a sleep aid. I guess I want to talk more about how can progesterone become a sleep aid.
Oh, good question. Um, I have a nice slide on that. I wish my computer was working, but when you take oral progesterone, it it's metabolized in the liver, and it changes into an alpha form and a beta form. Okay, and the alpha form is associated with sleep. It's like a sleeping pill, basically. So progesterone, and so what I do with patients, I start them off on a small dose, and I go up until they can sleep. Now I add magnesium, and I particularly like magnesium glycinate and magnesium taurinate. I particularly like those because they are the ones on magnesium threonate, but magnesium glycinate and taurinate moves through the blood-brain barrier, and so it chills you out. So I add magnesium along with my progesterone for sleeping. Transdermal progesterone doesn't do that because transdermal progesterone bypasses the liver. Remember, you're not taking it in by mouth, so it's not going to the liver and being metabolized. It goes directly into your bloodstream, and you don't get those metabolites. It's the metabolites of progesterone that behaves like a sleep aid.
Okay.
Okay?
Okay, that's good. So I was going to ask you about magnesium with that
Yeah,
progesterone. So you use
yeah.
magnesium
Glycinate
glycinate and taurinate.
and taurinate,
And
taurinate,
taurinate. Okay.
taurinate with a
So
T, T-U taurinate. Yes.
okay.
Yeah.
So these progesterone, so are they also bioidentical or those are you can
It's
get
it's
them over?
it's bioidentical. You remember long ago we had a progesterone called Provera. But if you remember Provera, Provera it is a synthetic. It was medroxyprogesterone, bad progesterone, bad. It's not even progesterone. That's the one that's cardiac restrictive, and that is the one that's associated with a heart disease when you add it to the estrogen. The Women's Health Initiative study was in um early 2000 when it was a big uproar and everybody
Right,
just took themselves off of I
right.
went that was not that's not the progesterone I'm talking about. That's
Okay,
Provera. It was Provera and Premarin. It was the horse's estrogen. That study was the horse's estrogen and Provera, which is medroxyprogesterone. Had nothing to do with what I'm saying at all. Okay,
right.
so this is a natural progesterone. By the way, insurances will cover a natural progesterone. There's one called Prometrium. It is bioidentical. Prometrium, bioidentical, 100 milligrams and 200 milligrams. You cannot get it 125, 125 milligrams,
Right.
150 milligrams in case you need it. You can only get it in 2 doses. That's all it is.
Okay.
And
Right.
you
So
will cover it. So there are some bioidentical prescriptions and estrogen that your insurance will cover. But you can't tweak them. You can only get them in 1 dose. See? And your estrogen is estradiol, and it's only estradiol. When I use my estrogen, I use estradiol and estriol. Estriol is a protective estrogen, if you could say that. It actually is anti-proliferative. So I use estriol and estradiol to protect you.
Okay, wonderful. Okay,
Yeah.
I guess you talk about flaxseed as a source of estrogen, or to keep,
Yes.
yeah. So they're asking, can flaxseed be replaced by chia seed? I guess to clear out those receptors we're talking about. You're talking about
Yes.
flaxseed can clear out those
It can do it. That's right. The xenoestrogen. It can
estrogens.
do that. It can do that, but it's just that they studied flaxseed for that. But I believe all of these seeds can do that. All of these seeds, the pumpkin seeds, sunflower seeds, hemp seeds, all seeds can do that. But they actually studied flaxseed for it. You see what I'm saying? It was actually studied. So we have papers on that. I don't remember seeing a paper on chia seeds or anything like that, but I think it should be able to work for that as well.
Okay. Someone is saying, can you share your office number? I guess.
Well, you could put it on the chat if you want to, Emlyn, when you have
okay, yeah.
Yeah, you could I can't seem to. I'm using my phone, so I don't have that capability, but you could. It's 352 48 if you want. 352 483 3730.
Okay. 352-483-3730.
If they want to do a email, they could do there's an office email. It's Healthy Choice. Okay, that's one. So it's healthychoiceobgyn@gmail.com. It's one word, healthychoiceobgyn@gmail.com. They can also email as well.
Where's my at gmail?
Yeah, .com.
Okay. Okay, so there's the number and email. OBGYN. Yes. Yeah. Okay, so you are requested in Tobago. We need you in Tobago, someone is saying. Dr. Wendy, we need you here in Trinidad and Tobago. When is it coming to Tobago next week?
I'll be in Tobago for 1 week between April 27th and May 4th.
Yeah, so those of you who are here in Tobago, Dr. will be here.
About that?
And pardon me?
Well, my brain start clicking now to get her at my church.
Okay.
Okay, so Mary's Hill.
What church do you go to? What church?
Mary's Hill Seventh-day Adventist Church.
Mary's Hill. Okay.
Yes.
Yeah.
Yeah.
Okay.
So Dr. Perrott just come to Tobago and she does lectures here in Tobago. I guess you will be at is it Lekito?
I would be in Mason Hall. On April 27th and Lekoto on May 4th.
So those of you in Tobago, take note of that. Dr. Perrott will be here. So she's she's all over the world. I
didn't know about her before us.
I'm telling you, we have knowledge here. So I love going to Dr. Perrott, visiting Dr. Perrott. We can sit and we can talk. I usually have my appointment to be the last of the day so I can talk to Dr. Perrott. I should have it later in the evening.
That's true. They usually knock on the door.
Yes.
Emily, I had my hands up.
Yes,
for a question.
Okay. Go ahead, Moya.
Yes, good evening, Dr. Perrott. I will look forward to see you in this neck of the woods
Okay.
And I'll do my personal advertisement for your coming. My
Okay.
it's just something, by the way. I was having real sleep problems after I entered menopause, and I use all sorts of bush, and well, you know what the Caribbean
Yes,
people would
yes,
do.
yes,
And
yes.
then someone introduced, I think it's my brother, who was having massive sleep problems because he had something with his liver, and he introduced me to magnesium glycinate. And I'm
Yes,
telling you, it really helps me to go off to sleep.
that's correct.
So
Magnesium
then,
glycinate.
well, most time, well, I don't take it like a day-to-day supplement, so I don't know if I'm wrong, but most times, like just before I go to sleep, I will take it, and within, like half an hour, I am quite ready for bed. I don't do it every night, but this magnesium glycinate,
Let
100
me tell
milligrams.
you, it does not hurt. You can do it every night. It is good for you in other ways too. It helps with electrical activity. Do you know if somebody and Emlyn, you can bear
Mhm.
me out on that because you did
Yes,
ICU nursing. You
yes.
remember how when a person come in with heart attack and stuff like that, the first thing we check is the magnesium level, and you remember
Magnesium
handing
and
magnesium.
potassium. Yes, and we
Yes,
have to,
absolutely,
yes, and we give them
absolutely.
magnesium boluses. We have to give them those magnesium and
There
get
we
that
go.
magnesium level up because it causes
And
arrhythmias.
every time the magnesium is always low. Magnesium is one of the minerals that we have, like it's almost a universal deficiency of magnesium. You know
Yes,
why? Is because we
yes,
eat our foods, do not we process our food so much. We take the grains out, we take the what they call it, the bran from the grains and all that stuff like that, and we decrease our magnesium. It's amazing. It's amazing how much magnesium white rice has to compare to magnesium in brown rice. It's like triple in a brown rice compared to white rice
Right,
because
right,
we process our food. We eat so much processed foods, so
right.
there's a deficiency, and then we come in with a heart attack, and we have to give it magnesium. So take your
Yeah.
magnesium every day. It's good.
Yes, yeah, yeah, that is so true. The first thing anybody come into, well, the ward I work is a cardiac ward, and we check everybody magnesium level because
Exactly.
it's not in that asteroid. I keep saying asteroid, but that CMB. So it's
Yes.
very separately every patient, and we do that sometimes every day. We check in these magnesium because it's so crucial for heart
Yes.
contractility. And
Crucial.
yes,
Crucial.
yes,
Yes.
yeah. So, I prefer taking the magnesium because I know some people say you can take melatonin, but I'm considering with taking melatonin to help you sleep. But melatonin is a
Mm-hmm.
hormone, and I prefer my
Mm-hmm.
body to produce something naturally and for me giving melatonin. So,
Mm-hmm.
so maybe instead of taking the melatonin, take that magnesium. I take 800 milligrams of magnesium a day. 400
Yes.
milligrams in the morning, and then before going to bed, I take another 400 milligrams
Right.
with my progesterone. So to
Right.
help with sleep.
Yep.
Yeah.
Absolutely.
thanks
Absolutely.
so much. Thank you.
You're welcome. Yes,
Okay.
I'll be in Tobago for a week.
Yeah. Yes. So let me
Yeah.
tell you, Dr. Perrott from Trinidad and Tobago. So here we go. We root, Trinidad and Tobago. Okay, Alisa, I see you have your hands up. Go ahead and ask your question.
Yes, good evening. I was wondering if the magnesium glycinate
Mhm.
is have to be prescribed by a doctor.
No, not at all.
How would you know what is good for you and what is not good for you, especially if you're on other medication like blood thinners and those things?
Okay. Now, blood thinner, it shouldn't be a problem with blood thinners. And magnesium is a kind of a benign type of mineral. You know what I'm saying? So I believe you could start off with 200 milligrams of the glycinate and go up until you're able to sleep. Magnesium, even with blood thinners, remember this, Emlyn, and Emlyn will bear this out. We
Yeah.
hang magnesium IV, and you're on blood thinners.
Right. Yes.
In an institution.
Yes. All those
Magnesium,
yes. Yeah, it's a mineral that our body uses. Yes. I don't think I don't think it's going to affect any other medications you're taking
No,
because
no,
it's a
no.
natural. Yeah.
It's a natural thing, yeah.
Yes.
But you know, you could still check with your doctor for sure. You know, but based on what we know, what both Emlyn and I know, I don't think there should be a problem. But if you want to double check with your doctor, you can. Yeah.
Okay, Sherilyn is saying, can you repeat the 4 labs, oh boy, the 4
Okay, the
labs
4 labs
that needs to
yeah.
be, or you can need to be tested?
Okay, so I look at evaluation of hormones in 4 areas. I look at insulin level and hemoglobin A1C. That's one area. So that's looking at your blood sugar dysregulation, insulin level, fasting insulin level, and hemoglobin A1C. The second thing I look at is your sex hormones, such as estrogen, testosterone, progesterone. Okay. The third thing I look at is your thyroid. So I'm looking at TSH, and sometimes I throw in a free T3, a free T4, and thyroid antibodies. May not have to be that extensive, but that's the third area. And the fourth area is your stress level. So I look at an AM, like in the morning, cortisol level. So those are the 4 areas I look at it.
Okay, so you just look at the
Okay.
AM cortisol level.
Yes,
The
because the AM cortisol level should rise at 6 a.m. in the morning. You should have a rise, and it should be somewhere between 10 and 20. And then it rises like a little mountain, and then begins to kind of go down, down, down until it gets to 12 midnight.
Yeah.
Or 8 p.m. And it really goes down at 8 p.m. until it goes down by 12, between 12 and 2 and 3. It will begin to kind of rise again until it peaks at 6 a.m. the next day. That's
Right.
what is. Now, let me say something I didn't say before, and that is circadian rhythm. Let me say something about circadian rhythm. We have a 24-hour circadian rhythm. You know, sun rises, sets, revolution of the sun, the earth around the sun. Now, it's important. The morning sunlight, AM sunlight, between sunrise and about 9:30 a.m. If you go and sit in the sun, walk in the sun, just sit and look and just let the sun bathe you for 30 minutes, you can increase your estrogen level. And you will fall asleep and it will sync. Your body is now being synced with your circadian rhythm. You have to sync your body with the circadian rhythm.
Amen.
Can you please say that again?
Okay. What I'm saying is that we have a circadian rhythm, and it takes 24 hours for the earth to make a revolution around the sun. Okay, so we have to sync our body to that. Okay, our bodies are not synced anymore because of stressors of getting up, of whatever, TV, light, all these kinds of things. So you have to sync. The way you do that, and it only takes 7 days to sync your body. So if you go into the sun in the morning between 6 a.m. and 9:30 a.m. for 30 minutes, whether you walk in the sun, sit in the sun, just get morning sunlight, you will sync your body with the circadian rhythm. And there are 2 benefits of that. 1, it increases your estrogen level, and 2, it improves your mood. There's a third, it actually makes you fall asleep at night.
Yeah.
I will stake my reputation on that. It make you fall. Sync your body. You will see about 7 days. Oh my goodness, by 9 o'clock, I feel a little sleepy, because you sync your body with the circadian rhythm. And by the way, if you want to do that regularly, because it takes your body about 7 days to do it, and if you don't do it in another 7 days, it goes away. So you want to do it pretty regular. Yeah.
Yeah. Wonderful. Dr. Perrott, I just love talking to you because you always have such wealth of knowledge. I'm going to stop walking with my shades. So I go walking in the morning, but I use my shades because it's trying to decrease the sunlight. It's in my face, but I think I need to stop wearing my dark shades so I can get
that's correct.
That sunlight.
That's correct.
Yeah.
The sunlight, yeah.
Yes. But thank you so much for coming and taking your time and sharing your knowledge with us. So, this presentation will be on our Zoom, on our YouTube, that once we get it downloaded, you can go there and listen to this presentation again. And those of you in Central Florida, wow, Dr. Perrott is here. You can call, make an appointment, and go visit her at her office. So thanks again, and thanks for everyone who came on to hear this presentation. I'm going to
Thank
stop.
you.
Thank you so much. Thank you. I'm going to stop recording.
Okay.